Next, I want to talk about focused cold therapy. And cold therapy is looking at for cryodestruction, but also looking at cryoanesthesia. And cryoanalgesia or cryomodulation has been known for decades. This is talking about Hippocrates back in BC as anti-inflammatory properties, refrigerants in 1899, first liquid nitrogen in 1950, Cooper liquid nitrogen reached minus 190 degrees, CO2 in 1967, and then they found a way to reduce cryoanalgesia in peripheral nerves without destruction at this point. And the idea is this second-degree injury where you can get temporary reduction in pain without destroying the nerve. You get regeneration, and the idea is to have the correct temperature. And that's the mechanism of action. You want a temporary effect like you get with botulinum toxin without permanent damage. And so you're affecting these aspects of the nerve, including the myelinated and unmyelinated fibers and various aspects of the fibers so the nerve can grow back without it being permanently damaged. The idea here is to have reversible second-degree damage, loss of continuity, but preservation of the endo, peri, and epineurum. So that's the idea of this category. So here, we want the second-degree effect with the axon and myelin without the non-reversible effects. And this is just showing the idea of, wait, let me go back for a second. I should be able to go back for a second. There we go. Of having the effect on the nerve and then being able to retreat this over time. Here are some of the histologic aspects. Here are the axon measurement access and some more histology of the effect on just the nerve, but not on the fat and the glands. There's some preclinical data. This is rats, and the rats underwent exposure to the nerve, and they looked at this in terms of movement over time. And you can see here the issue of the first, second, and third treatment. And each time they did this, they got this change in activity in terms of the treated toes, the toe spread, meaning you couldn't bring it together, and you can see how that went back to normal over time. Technology is very interesting. Traditional, this is a cryo system, which is big. This is now focused cold therapy. The company is named Myoscience. They actually have an FDA-approved device that is very precise, simple, and minimally invasive. Let's see if I can get this to work. Yeah, so the cryogen goes to the tip. It heats the tip on the bottom but does not heat the other areas, so you're just getting it down, not to destroy the skin, but to, in this case, the nerve. But you can think about this with other tissues also. I'm not sure I'm going to get this to work. But anyway, the idea is this goes in the skin and just heats that lower aspect in this agarose gel model. Okay. There we go. Clinical data. The idea of this for pain has tremendous implications. They're looking at osteoarthritis in the knee, occipital neuralgia, forefoot pain, with many study endpoints for this. This is really what's very interesting. I have many friends who have knee pain, and we've looked into this from knee pain. Here's the study for 33 patients looking at treatment with this device. The AEs were fairly mild. This is really a fairly painless treatment. The idea is you want to treat the infrapatellar branch of the saphenous nerve, which is where you get the aspect of the knee pain. Here are the VAS scores. The nice thing is this occurs immediately. Unlike with toxin, you get the effect on the nerve immediately. So immediately post-treatment, you could see a VAS score of 7 going down to a 1 or a 2. And this is very, very significant. This stays day 30, and it probably comes back in about 3 months and needs to be retreated. This is the difference of pain, stiffness, and function pre-procedure and post-procedure. So think of this also in terms of being able to treat this before knee changes, in terms of replacing of the knee, because that's one of the most painful surgeries. You can actually cause a much better rehabilitation with this type of treatment. Great occipital neuralgia has also been looked at with this, but what is the implications for dermatology? And I think this is the most exciting. Number one is postherpetic neuralgia, and that's being looked at or be in the process of being looked at. to treat this. This is something we may be able to get immediate results. Intense localized itching. Hyperdynamic wrinkles. Susan Winkle will be giving a talk on this later on the data. It's actually improved in Europe for frontalis as well as in Canada. But also think of this as being able to destroy fat locally, putting in a little cannula and being able to destroy a lipoma, submental fat or other fat locally. It's very, very interesting. So this technology may be ideal for reversible analgesia, FDA approved, clinical applications including pain. For us as dermatologists, pain, postherpetic neuralgia, chronic itch, the frontalis model in terms of hyperdynamic lines, and possibly fat.